About 4 million Kenyans have kidney-related ailments, and this number has been rising sharply in the last decade. To manage the condition, most rely on routine dialysis, which is costly. The National Health Insurance Fund foots most of the bills. On Health Watch, we take a look at the recent step by NHIF to allegedly reduce funding for dialysis, and we examine what this means for patients. My name is Saada Hassan. Kidneys are tiny pairs of bean-shaped organs on either side of your spine, just below the ribs and behind your belly. Roughly, they are the size of a large fist, measuring about 4 to 5 inches long. Despite their size, they play one of the most important roles in our bodies. They filter blood by removing waste, balance body fluids, and maintain just the right levels of electrolytes. Interestingly, all blood in our body passes through them about 40 times every day. Therefore, any failure to their normal functioning can be disastrous. In the last decade alone, kidney diseases have increased tenfold across the globe, and Kenya is no exception. Kidney disease is projected to become the number 5 leading cause of premature deaths globally by the year 2040. This is according to a report published by Lancet on the global burden of chronic kidney disease. Due to the costly treatment needed, many Kenyan households cannot afford out-of-pocket spending. As a result, a huge number of patients highly depend on the National Health Insurance Fund, or NHIF.
The dialysis package has been a very, very popular package because from the time that we started, I know we started at a very low amount of reimbursement, 2,500, then went up to the 9,500 for 2 sessions. It means that a patient who is undergoing dialysis actually benefits over 900,000 shillings in terms of benefits from us, from what they just contribute of 6,000 for their family per year.
Currently, NHIF caters for 2 dialysis sessions a week per patient at a cost of 9,500 shillings. With the recent proposals, this spending will shrink to a cost of 6,500 shillings per session. But the patients will benefit with a 3rd session. So what does the proposal mean to NHIF, bearing in mind that there is no cost cutting with the new proposal?
The proposals that are there is to have 3 sessions so that even those with severe forms of end-stage renal disease actually do get that chance. And the reimbursement amount, we're looking at what the current rates are, we're looking at what the ministry had advised, we're looking at our interactions with the stakeholders, including suppliers, to ensure that we are able to support both the providers and especially the patients. Because why are we here? We are here to ensure that the patients have access to healthcare. We know that even as technology is advancing, even the costs of the inputs, because of the high volume of facilities that are available now, and there's a lot more, there's an increase in supply, the costs have also come down of the inputs. In fact, it is interesting that I think at the time when we were starting in 2015, I think there were only about, I think less than 20 dialysis machines. And right now, the total number of dialysis machines is over 1,800. This is as per the reports that you'd get from the Kenya Renal Association. And this shows the increase. And what makes me happy is that it shows that there was a huge gap that we are filling. Now, to ensure that we become sustainable, we have to look at the cost so that we get to that sweet spot that everybody is able to access.
According to the Kenya Renal Association, the move does not make sense to local patients since they were not involved in the process. The statement reads, in part, "For the avoidance of doubt, we kidney patients have not asked for a 3rd session and would rather not have it if it comes at a cost to us or the risk of compromised dialysis service or worse." However, Dr. Kamunyo says that the move is not aimed at hurting patients.
No, the intention is not for the patients to top up in any way whatsoever. This has been a consultative engagement throughout this period. And also, as you know, from the ministry, there was a harmonized benefit package that was to be now for UHC that had been proposed. So one of the key things that also came up from the kidney, from the dialysis, is that we reimburse for 2 sessions, yet patients with severe forms of end-stage renal disease require 3. So they were being left out, and a lot of them, if they were unable to afford that 3rd session, would end up in not very favorable outcomes. So looking at the benefits review that we have done is to ensure we address those needs.
There are different procedures done to patients with kidney ailments. Some go for dialysis, peritoneal dialysis, while some undergo kidney transplants. Jackie Riba, who is a nephrologist nurse, explains the process.
So this is a hemodialysis machine. The patients are connected to the machine, and by use of these gadgets, it's an artificial dialyzer. It's called a dialyzer, an artificial kidney, and the blood lines, plus the other components of the machine. So basically, when the patient comes to us, we usually take their weight, we take their blood pressures, we check on their general condition, and of course, they are in renal failure, then we connect them to the machine. So basically, what the machine does is that it is getting blood from the patient through this red line. It's called the arterial line. It is pushed to the dialyzer by use of this machine, and then there's some concentrate that the machine also picks, and it is pushed into the dialyzer by a machine, a pump which is inside there, and both of them are pushed. There's some pressure which is applied in the dialyzer, and because of that pressure of both the fluid and the blood, we do what we call ultrafiltration, and then through which we remove the fluids. And then we also do osmosis and diffusion, where we remove all the unwanted waste from the blood. So after the blood has been cleaned, it goes back to the patient through these blue lines. And then as the patient dialysis, we're supposed to monitor on how the patient is improving by checking continuously on the blood pressure, possibly every 1 hour or 2 hours. And then we also monitor the pressures of the blood, which is getting to the patient through this line, and the pressures of the blood coming from the patient through these transducers.
Globally, kidneys are the most transplanted organs. In 2019 alone, 7 different hospitals in the country, including Kenyatta National Hospital and Moi Teaching and Referral Hospital, carried out approximately 163 kidney transplants. But the biggest challenge for kidney specialists is not whether the transplants can be done, rather whether the recipient can maintain the new organ and avoid rejection. This needs lifelong medicines known as immune suppressants.
When we look at 2018 and 2017, the young people who came back from transplantation dialysis did so because they could not afford medication. When patients come for transplantation, they undergo a rigorous counseling process. And within that counseling, we do social work on them. We try to ensure that those patients who finally get kidney transplantation are able to afford. So we will probably not take in a person who will demonstrate that they cannot be able to afford medication post-transplantation because the kidney might be rejected too soon. But having said that, fortunately, we have not had many people pulling out because they have not demonstrated that they cannot afford to pay within the first few months.
The major risk of a kidney transplant is the body rejecting the new organ. This can happen if your body's immune system treats the kidney as foreign. To prevent this, one must take medicines to weaken his or her immune system. These medicines are required for as long as the new kidney remains viable and in use, basically for the rest of one's life.
The biggest challenge we have been having is not much more so providing the kidney transplantation itself, but more importantly, maintaining immunosuppression, ensuring that the kidneys in these patients stay well for many years to come. Because these patients require immunosuppressive medications, they require drugs, and these drugs are taken every day of their lives. If they don't take a drug, say they miss, then kidneys could undergo what is called rejection.
NHIF currently covers the actual transplant surgery costs, both for the donor and the recipients, but that is where it ends. The insurance fund covers up to 130,000 worth of cost for up to 5 to 7 days. After this, one has to cater for the rest.
The intention is to ensure we get a comprehensive package for transplant so that we can transition patients on dialysis to transplant. Because we all know that in the long run, it is actually not only cheaper, it also improves the quality of life of the patients. Because going for dialysis twice a week or 3 times a week for the number of hours is really debilitating to the patients. So we are looking at ensuring that we are able to transition. Currently, with our benefit package, the transplant is done, and we have done several and paid for several transplants. But the challenge has been on the post-transplant medication. And we are looking at how do we ensure that we get that, because that post-transplant medication, as you know, is quite costly. I think the market rate is anywhere between 30 to 60,000 shillings a month. So looking at, as we are looking at strategic purchasing, is as part of our reforms, we're looking at how do we derive partnerships, even with other government agencies through Ministry of Health, through KEMSA, or even through the manufacturers, to ensure that this medication is actually available affordably for us to be able to reimburse on outpatient.
Even with more than 7 hospitals in the country, including Kenyatta National Hospital, Moi Teaching and Referral Hospital, and other private hospitals being able to do kidney transplants, there are those who still prefer seeking these services in foreign nations. Due to increased cases of kidney-related illnesses, NHIF payments for renal dialysis have more than tripled in the last 4 years. High blood pressure or hypertension and diabetes are now the most common causes of kidney disease. Up to June this year, the insurer paid just over 3.8 billion shillings for slightly above 25,100 claims for patients who sought renal dialysis. This represents a 208% increase in NHIF paid for the same in 2017.
As a national insurer, the interplay, because we do not provide any service ourselves. So the person who provides or delivers our promise is the provider. But at the same time, I am sure the provider would want us to be present tomorrow and into posterity. So we have to ensure that we do get that sweet spot, that we are able to ensure that they're reimbursed fairly, and at the same time, we provide adequate services for our patients.
With the shifting dynamics in the health sector and the rising burden of non-communicable diseases in Kenya, Kenyans may have to dig deeper into their pockets to get the necessary medical services as we wait for proper financing and health systems to be actualized. This may be a long time coming. For Health Watch, my name is Saada Hassan, KTN News.